All right, and finishing up chapter 22 by looking at those diseases that affect the lower respiratory system. All right, so now the two that we'll focus on with the lower respiratory tract is tuberculosis and pneumonia. So first of all, tuberculosis. So it has a couple different kind of stages or events. So primary tuberculosis, this would be an initial infection of TB. Its infectious dose, again, that term just means the amount of bacteria needed to cause an infection. It is extremely low. Only 10 bacteria do we need to come in contact with in order to get tuberculosis. So it has an extremely low infectious dose because it's so pathogenic. And what's unique about these guys is the bacteria actually multiply inside of phagocytes. So macrophages, phagocytes, again, they're supposed to eat the bacteria, break it down using lysosomes, and spit it out. Well, this mycobacterium that we'll learn about here in a minute, it is actually able to not only survive inside of those phagocytes, but they actually multiply inside of them. So it evades the immune system. It also produces what are called tubercles, and these are granulomas or collections that have the bacteria in them with those macrophages. And the macrophages get really big because the bacteria keeps multiplying inside of them. And then they're surrounded by fibroblast lymphocytes like B and T cells and other macrophages. So it creates this big cluster. And they can become necrotic and lead to lesions that can then calcify. And that's what we're seeing here in this picture. Let me get a different color. That's what we're seeing here is some of these calcified lesions of these granulomas, which are just clusters of these macrophages because, again, they can't get rid of the bacteria and they're getting bigger because they're multiplying inside of them. So the skin testing, if you're going into healthcare, if you haven't already, you will receive this skin test, and it's looking to see if you've ever been exposed or ever had tuberculosis infection. So they're responsive T cells to that tuberculosis protein. So essentially what happens is one of the proteins from the causative agent Mycobacterium tuberculosis causes that cell-mediated immune response. And so that's evident by the skin test. So there's an injection here of one of the proteins. Again, it doesn't actually cause tuberculosis. It's just one of the proteins. And what they're looking for is to see if you have any immunity to it. So if you've been exposed to tuberculosis before, then what's going to happen is you will create an immune response. So your memory cells would recognize it, and it takes a couple hours or a couple days, but ultimately you would have a positive test where you get kind of a bump or an allergic reaction to it. And again, that indicates that you've had a primary infection of tuberculosis. Now, the reason that's important is because secondary tuberculosis can occur. So individuals who have had tuberculosis, oftentimes because of those granulomas, it never completely goes away. And so it can lead to this secondary reactivation where those dormant bacteria in the lungs actually get reactivated, especially as the immunity wanes if they get some other infection. Then even though those can remain dormant for years or months, it leads to a very severe symptoms, much worse than the primary infection. So it causes violent coughing, sputum or mucus that's greenish and bloody, fever, anorexia, weight loss, fatigue, and chest pain. And so if untreated, it can actually lead to about a 60% mortality rate. And this is one of the reasons that it's tested for in healthcare, is they're looking to see if you've had a primary tuberculosis infection, because it may have been asymptomatic. You may have never even known you were exposed to it. But again, it can become dormant, and it means that you could have this secondary tuberculosis. So it's something that needs to be detected. Now, the causative agent, as I mentioned, Mycobacterium tuberculosis. This is an acid-fast bacteria. So we haven't talked about these in a while, but acid-fast means it produces this waxy called mycolic material on the outside of their cell wall. And so acid-fast is the type of stain that identifies them. So we have like the Gram stain. Well, the acid-fast stain specifically identifies these Mycobacterium species that have this mycolic waxy cell wall. It also makes them really hard for our immune system to recognize it because of that lipid component. It does take them longer though to replicate, so it takes almost a day for them to go through and reproduce, so that generation time. So it means that while it only takes 10 to cause an infection, it's a while before you start to see symptoms because it takes them so long to divide. But because of that mycolic acid in those waxes, it makes them virulent. Our immune system doesn't recognize them. They're resistant to drying and resistant to disinfectants, so they're hard to treat. And again, it's hard for our immune system to recognize them. And there's also what's called the MAC, so the Mycobacterium avium complex. So this causes a disseminated tuberculosis, and this is in AIDS patients or other immunocompromised people. So again, that effect, because they both decrease our immunity and our immune system, it allows these complexes to form. All right, so moving on now to our pneumonia to wrap us up. So this anatomical diagnosis is typically what's used. So they're looking for inflammation in the lungs. So typically an X-ray is done looking for that to diagnose it. It is caused by many different organisms. And these are all able to avoid phagocytosis, or they could even, or if they're phagocytosed, that they're not killed once they're inside of the macrophages. So they either don't get phagocytosed, or if they do, they're not destroyed by them. Viral pneumonia is usually, not always, milder than the bacterial. And then fungi can also cause some types of pneumonia. So again, a variety of microbes can cause pneumonia. And then just some numbers here, not that I would test you on this, but just to put in perspective the importance of understanding pneumonia. There are about 2.2 to 3 million cases and about 50,000 deaths per year that occur due to pneumonia. Now we'll talk about community-acquired and hospital-acquired pneumonia. Community-acquired is something you would get from other people. So just from direct or indirect contact from somebody who has pneumonia and you were exposed to it, whether directly through their coughing or on a doorknob or on a table that they coughed on. Again, you're getting it from somebody else. So those are community acquired. There are a few different ones that we'll highlight here. So the main causes of community acquired pneumonia, Streptococcus pneumoniae. Again, we've mentioned this one before because it can cause other infections. As the name implies, it's a coccus bacteria, so it's circular. Strep meaning it forms chains. It is gram positive. It produces alpha hemolysis, which if we put it on a blood agar plate, you can see the bacteria growing and it causes clearing. So it breaks down these red blood cells. We've talked before about beta hemolysis. Again, alpha hemolysis is just, it looks a little different on the blood agar, so it can be distinguished. These also produce a capsule that prevents that phagocytosis. Again, all of these need to be able to prevent or survive phagocytosis. Now, as we mentioned before, whenever we were talking about the normal biota, this is part of that normal biota. So about half of the people actually have this as part of their normal flora. The problem is whenever they get an infection, whenever that bacteria is inhaled deep into the lungs, so overexertion, if somebody's breathing very heavy for various reasons, it goes deeper into the lung tissue than normal. But it can also occur just from people sharing droplets, so of course kissing or direct contact as well. Another cause of community-acquired is Mycoplasma pneumonia. This causes what's called atypical pneumonia because the symptoms don't look normal, so it's atypical. What's unique about Mycoplasma, it does not have a cell wall. So it has lots of different shapes because the cell wall determines whether it's coccus or bacillus. Mycoplasma, all of these organisms lack a cell wall. One of the only bacteria, the genuses of bacteria that don't have a cell wall. Transmitted by those aerosols, and this also leads to walking pneumonia. And essentially diagnosis is kind of by ruling out a lot of other causes. Another one is Legionella pneumophilia, and this is weakly gram-negative, and it can have a lot of different shapes. It is associated with human disease after the American Legion Convention in 1976. That's what caused the naming Legionella, because there was a convention of the American Legion, led to an outbreak, and it was named after that event. It is distributed, though, in aqueous environments. It didn't just appear then, it was just an outbreak. So things like tap water, cooling towers, ponds, fresh water. It is opportunistic. Okay, so again, opportunistic means that normally if we're exposed to it and we're nice and healthy, nothing bad happens. However, in elderly people, children, in some cases, or again, those who are immunocompromised, they can develop this pneumonia from this opportunistic pathogen. Histoplasma capsulatum. This is also known as Darling's disease, Ohio Valley fever, or spelunker's disease, like caving. This can be completely benign in some individuals, or they wouldn't even know they had it, or it can be extremely severe. It can be acute and over within a week or so, or it can last for weeks or months. So again, a lot of variety, kind of like we've seen with COVID, but this bacteria, it ranges between individuals. The most serious forms, though, are those who have AIDS. So this Histoplasma capsulatum is the main one that causes pneumonia in AIDS patients, and it also is a more serious form in those patients. So this chronic pulmonary histoplasmosis is also a disease where everything looks very similar to tuberculosis, but it's not quite the same. But it is endemic, especially on all continents. The only exception would be Australia, but it is found worldwide except in Australia. And then we also have another one here that we are concerned about with AIDS individuals, and this is Pneumocystis jirovecii. And this individual here that causes pneumocystis pneumonia, or PCP pneumonia, again, this is only actually one that occurs in individuals with AIDS. So the organism used to be called Pneumocystis carni. So again, it's been updated, though, for various reasons, but it's probably part of our normal flora in most healthy people. But again, in individuals with AIDS, as their immune system weakens, it allows these opportunistic pathogens to kind of take over. So the fungus actually multiplies intracellularly and extracellular, so it can be inside or outside. And so traditional antifungal drugs, though, are not effective against this. So things that we could use for various, like that target various unique fungal features, do not work against this one. So one that's caused by a fungus, again, individuals with AIDS is the target audience that we talk about these with. So then our summary table here of the community-acquired pneumonia. So again, we have various viruses that are, again, can be secondary, like we'd seen with the cold, Streptococcus pneumonia, and then the micrococcus. Again, slight variations. So Streptococcus can form that capsule. Mycoplasma doesn't have a cell wall, but it has adhesins that allow it to attach, so that both of those forms can be treated with antibiotics. But again, the Streptococcus pneumonia, it's one of the serious threats to the CDC. So it causes severe, or can cause severe pneumonia. Our other ones, Legionella, Histoplasma, and then Pneumocystis. Again, Pneumocystis is the fungal one of the group here. Histoplasma has the ability to survive inside of those phagocytes, and whereas the Legionella and the Pneumocystis don't have a lot of virulence factors here that we talk about. Now, as we switch into the healthcare associated pneumonia, about 1% of hospitals, of individuals who are hospitalized, get pneumonia. So this isn't something they would get in the community that we just talked about. This is associated with you are in the hospital for one thing and you end up getting pneumonia. So it's most often associated with mechanical ventilation or endotracheal or tracheostomy tubes. So something that is, being physically inserted into the lungs. The reason we talk about it, thankfully, it is only about 1% of individuals in hospitals. However, the mortality rate is very large, so 30 to 50%. As you can see, lots of causative agents that can lead to this. So MRSA, for example, like Staph aureus, Klebsiella pneumonia, Enterobacter E. coli, Pseudomonas aeruginosa, Acinetobacter, and then a lot of them are polymicrobial, meaning it's more than one of these agents that are causing it. So there are different causative agents than what we've seen with the community acquired. So the prevention and treatment, so again, most are due to aspiration from the upper respiratory tract. So keeping patients' heads elevated, especially helps to reduce that aspiration of secretions that brings it in there. So deep breathing and frequent coughing just to get rid of things to keep everything nice and oxygenated. Using proper care of ventilation and respiratory equipment, making sure that it's sterilized properly, that it's used and inserted properly. Empiric antibiotic therapy should be started as soon as somebody is suspected of having this because of that mortality rate. So treatment quickly, treating it very quickly is very important. All right, so our healthcare, again, many causative agents. In there, again, it's more of an endogenous, so it's aspirated from part of their normal flora, from the upper respiratory tract that gets into the lower where it shouldn't be, or from, again, using various devices that are inserted into the lungs, and they take those bacteria or those microbes with it. So again, elevating the head, again, proper education and proper care and use of respiratory equipment is what prevents these. Then just summarizing this chapter here with our tables. So again, looking at our diseases. So we have Streptococcus pneumonia that can cause ear infections and pneumonia. Strep pyogenes causing our sore throats. Sore throat also caused by the Fusobacterium. We get whooping cough caused by Bordetella. Other sources of pneumonia, so the Legionella, as well as the Mycoplasma. TB caused by the Mycobacterium, those acid-fast organisms. Then looking at our RNA viruses here that can cause RSV, the flu. We didn't talk much about the hantavirus, but it's also caused by a viral infection, and there can be pneumonia caused by viruses as well. Then our fungi can lead to ear infections. We didn't talk about the histoplasmosis, but it can cause that. And then the pneumocystis pneumonia in those AIDS patients is caused by this fungi as well. And then our summary person here at the end. Again, most of these are bacterial infections or viral, but there are some fungal infections that can cause pneumonia, as well as some sinusitis from those as well.